You're listening to Medscape's In Discussion series on respiratory syncytial virus in adults, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Forrest Arnold. Dr. Arnold is the chief of the University of Louisville Division of Infectious Diseases and director of the Center of Excellence for Research in Infectious Diseases. He also acts as the co-editor-in-chief for the Journal of Respiratory Infections and program director for the Clinical Fellowship in Infectious Diseases. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Forrest Arnold, and welcome to Medscape's In Discussion series on RSV in adults. Today we'll be discussing RSV from the perspective where most of us have our landmark knowledge, which is in infants, to build a base as we discuss RSV in adults in future episodes. Dr. Statler is currently an assistant professor in infectious diseases at the University of Louisville and the director of the Pediatric Transplant and Immunocompromised Host Service at Norton's Children's Hospital. Welcome to In Discussion.
Thank you, Dr. Arnold. I appreciate the invitation to speak today.
Great. I would like to start with a case. So consider a 3-month-old who is brought to the ER with a 3-day history of rhinorrhea, congestion, and cough. A fever started today, which prompted the ER visit. On exam, the infant has wheezing bilaterally. A nurse performs nasal suctioning and checks a pulse ox. And I ask you, Dr. Statler, what is your approach to this patient and what happens next in the workup of this infant?
Sure. So this infant's presentation is very typical of many infants and young children coming to our ER in the fall and winter of most years. And it seems like this child has probably an upper respiratory or started with an upper respiratory tract infection. That sounds like it has probably gone into the lower respiratory tract since you have wheezing on exam. Our initial assessment is really to see if the patient is in a lot of distress and try to gauge how much distress the patient may be in. And then to look at the pulse ox and see if the infant is getting adequate oxygenation. And then from there, just kind of doing our basic physical exam, listening to the infant. This sounds like a bronchiolytic to me, just in your description. And usually the bronchiolytics on auscultation will have diffuse wheezing. You may hear some diffuse crackles and rales, and they'll have a prolonged expiratory phase as well. When you first look at them, some of them may be nasal flaring. They may be having some accessory muscle use. You may see subcostal or suprasternal retractions, and those are all kind of clues that help you gauge just how sick the infant is.
I see. Very good. So that's your approach for that. Now, this past season for RSV was incredible. I think we're all familiar with how severe it was. And I'm interested in what aspects of the season stood out to you.
Yeah, so before the COVID-19 pandemic in early 2020, most RSV seasons were pretty typical. You kind of knew when they were going to start, you knew when the number of infections were going to peak, and you sort of knew when it was going to fade out. Now, there was, of course, some regional variation in the United States, but typically a season would start in the late fall. So usually you would start to see some cases trickle in mid to late September, and then you would see kind of a peak in late December to mid-February. And then by the time spring kind of rolled around in most temperate climates, a lot of the cases, you would see much less circulation of RSV. This year, we saw RSV really start to tick up in August and September and really peaked in November. And it came in with a vengeance this year. So we saw a lot of patients in a very short time period. And really, to my knowledge, I think had a much higher hospitalization rate this season than we have in the past. It's interesting because the COVID-19 pandemic really disrupted the circulation of RSV and a lot of the other common respiratory viruses. And so after COVID kind of came around in March of 2020, that following fall and winter, when we would typically see RSV and flu, we really saw no RSV in 2020, 2021, that season. And then we started to see some RSV early in 2021, where we started to have like an uptick in the spring months of 2021. And it really peaked in July that year, which was completely abnormal and atypical for an RSV season. So we're not quite back to the typical circulation of the respiratory viruses after the pandemic yet.
When we enjoyed that flat line in 2020 and 2021 of no RSV, At the same time, that means there was a whole group of people out there, especially children, who had not developed antibodies because they had not gotten infected. It's almost like the next season, it was just loading up for more people. Do you think that's kind of contributed to the larger season we had this past year?
I think that's a great hypothesis, and we've talked about that locally with some of my colleagues about how we have this whole group of children who were born in the midst of the pandemic who really didn't have the typical exposures in their first year of life because we did not see a lot of the common respiratory viruses.
Right. Okay. Well, I have in front of me a figure from the CDC that outlines the last 5 seasons for RSV, and it shows the hospitalized cases per 100,000 population. And what we see is that each year, and if you look back at 2018-19, the season peaked about the end of February. But each subsequent year, it was a little higher and a little sooner each year, except for the 2021 season that was flatlined. And so by the time you get to this year, as you said, it peaked in the end of November. So it was February, then January, then December, and now November. So what are your comments about how this has played out?
Well, I think it really took us by surprise this year. After the little bit of a summer surge the year before, we weren't really sure what to expect with the RSV season this year. So I think we actually saw co-circulation of SARS-CoV-2 and flu during that time, and we had quite the surge in our hospitalizations and in our ER visits. And in fact, I believe the numbers, if you look at the number of hospitalizations in children under 5 for this past season, like at its peak, it was almost 64 per 100,000 when I look at the most recent numbers that the CDC has put out on RSVNet. And that's significantly higher than it has been in previous typical seasons.
Oh, very high. Yes, impressive. So when we think about the child that was presented at the beginning, what diagnostics do we have for RSV?
It's interesting that you ask that. So before the pandemic, again, a lot of times we didn't have to use a diagnostic test. If it was the middle of November or December and a child came in with wheezing and symptoms that were consistent with bronchiolitis, many times we didn't even have to test them. You could make that diagnosis on history and physical alone. You knew it was RSV season. It was probably RSV causing that episode of bronchiolitis in that child, especially if they were in their first year of life. But now, because of the atypical season and circulation that we've been seeing, we tend to use an RT-PCR on a nasal swab. And the ones that we've been using locally actually have flu and SARS-CoV-2 on them as well. So we kind of get to see 3 different viruses with one swab. And so that can help us diagnose RSV or one of the other 2. So we use that. We also have a bigger multiplex PCR panel, kind of a respiratory pathogen panel that has like 16 or 17 other viruses and some bacteria on it as well. We don't tend to use that as frequently, although I will use that in a lot of my immunocompromised hosts because it's important for us to know if there's a different virus there for those patients.
Okay. On the adult side, that is exactly how we approach the patients, especially, every year there's an epidemic of influenza. And so we don't rely on a test per se. Our diagnosis is our history and physical exam. And so that's consistent. We can't escape without talking about treatment. So maybe a short conversation, but tell us about treatment for RSV.
Yeah, sure. So there is no specific pharmacologic treatment that we use for RSV in children. The mainstay of therapy is supportive care. It's important to assess their oxygenation status. So checking a pulse ox is important and giving them supplemental oxygen as needed. We usually give that via nasal cannula. It's usually a humidified oxygen source for those patients. We assess that by taking a pulse ox and seeing if they have consistent desaturations less than 90%. And if they do, then of course we give them humidified oxygen in usually an inpatient setting. The other things we assess are their hydration and feeding status. So some of these infants who are breathing really hard can't eat also. And so we do have to assess their hydration status. So some of these patients will be admitted for intravenous fluids or for nasogastric feeding if they're unable to feed on their own. And then beyond that, those are the 2 main things. And then suctioning. So at home and in the outpatient setting, you can use bulb suctioning. These infants tend to have a lot of mucus production, and suctioning the nose and the mouth actually helps that a lot. In the hospital, we can actually do nasopharyngeal suctioning as well, which is a little bit deeper suctioning that helps some of the more severely ill infants that end up needing hospitalization.
Okay. So up to this point, we've seen how severe this season is with a peak of 64 hospitalizations per 100,000 population. And we also see that the treatment is supportive care, which includes suction, hydration, and supplemental oxygen, which kind of leads to the emphasis of prophylaxis of RSV. So can you discuss that for us, Dr. Statler?
Yes. So as you know, we do not have a routine vaccine for RSV, although I am excited about what is probably on the horizon for children and adults too. So we currently have a passive prophylaxis product called palivizumab. It is a humanized immunoglobulin G monoclonal antibody that binds to the conserved site on the RSV virus, the F protein. That is on the viral surface and usually has to undergo a conformational change in order to bind to the respiratory epithelial cells in the host. And so palivizumab is actually a passively given antibody product to high-risk infants. And that monoclonal antibody basically binds to that F protein before it can make that conformational change, and therefore preventing the virus from being able to bind to our respiratory epithelial cell and getting into the lungs, into those cells and replicating. So we do have that in our arsenal, and the American Academy of Pediatrics has put out guidance for who they recommend that product be used for. And so at this point in time, we do not give it to all infants. There's only a select group that are at the highest risk for severe RSV disease that it is recommended to be given to. And those, according to the AAP guidance, are infants who are born at less than 29 weeks gestational age and are in their first year of life and basically their first RSV season. And then other infants who have chronic lung disease of prematurity, so meaning that they were born at less than 32 weeks gestational age and required supplemental oxygen for the first 28 days of life. If they are in their first year of life, then they qualify for palivizumab prophylaxis as well. Those same children, those same infants in their second year of life, if they are still requiring some medical therapy or medical support for their chronic lung disease in the 6 months leading up to RSV season, they may also qualify for palivizumab prophylaxis. And then a couple of other groups that are more near and dear to my heart, we also give palivizumab prophylaxis to children who are under 2 years of age who are severely immunocompromised. And that does include our heart transplant recipients as well. And then infants who are in their first year of life who have hemodynamically significant heart disease or who have airway abnormalities or who have a neuromuscular disorder that may impair their cough. It also should be considered for those children as well.
Okay, so it sounds like those who are less than 29 weeks in their first RSV season, and this may include infants who have chronic lung disease. And those infants with chronic lung disease may go on and still be a candidate in their second year of life. And then you have another group of people who are less than 2 years of age who are immunocompromised or have specific comorbidities.
Correct.
Is there other discussion about palivizumab you need to share?
Well, so palivizumab is one of those things that these infants will get each month during RSV season, usually for a maximum of 5 doses. So again, prior to the pandemic, they would start to get their palivizumab in October or November and kind of go through March, April of the same year. And the AAP has actually put out guidance for this past season and for our current season that because of the unusual and atypical seasons we've had since the pandemic, there may be some infants who end up getting more than 5 doses because the RSV season has started a little bit earlier and we weren't sure how long it was going to go. So some of these infants may end up getting more than 5 doses. And the American Academy of Pediatrics has put out some guidance to help support that.
Well, fortunately, this season, as radically increased as it went, it seems to have dropped off just as quickly. So that's good.
Yeah, we have not seen, thankfully, as many cases here in late March.
Okay. Now, we heard of the concept with COVID-19 about flattening the curve. And so by doing that, you would have more resources in the hospital. But RSV did not afford us that opportunity. And without a vaccine, there weren't many efforts to flatten the curve, so to speak, and spread those infants over the whole season and make it easier on you guys taking care of these infants. Would you agree?
We saw a lot of patients in a very short period of time this past late fall.
Exactly. Okay. Well, great. We all know that antibiotics are not indicated for viruses, but is there a role for antibiotics with RSV?
Yeah, so in general, antibiotics are not indicated for infants with RSV. So first of all, it's pretty rare that these children will have a superbacterial infection along with their RSV. And so some younger infants who may also have fever may get some additional workup, but it is rare to see bacteremia or some other serious bacterial infection. Occasionally, you will have some patients who have an acute otitis media, and so typical antibiotics for the treatment of acute otitis media may be indicated in those cases, but just for RSV bronchiolitis, they are not indicated. There's really not, like I said earlier, a lot of pharmacologic products that we can use in RSV bronchiolitis. Even bronchodilators have not shown consistent clinical benefit. Steroids have been looked at as well and have really not shown any consistent clinical benefit for the treatment of RSV in children.
Okay. And you mentioned co-infections, which makes me think also of viral co-infections. And so the short viral diagnostic test that has flu, COVID, and RSV on it, I wonder if you've seen this season children or infants who did have RSV and flu or RSV and COVID.
That's an interesting question. I personally, anecdotally, have not seen those particular co-infections. Now, I have seen RSV with rhinovirus, so on that more extended multiplex PCR panel that we have, I have seen a few of those co-infections. I can't think of any off the top of my head that have had both RSV and COVID or RSV and flu, although I'm sure that has probably occurred this season.
Yeah, and you would think these infants would be so susceptible to COVID-19 because talk about a novel infection, they're a novel human. And so they really have not seen it.
Right.
Unless, maybe they have some antibodies if they were maternal. When we had our flatline of RSV during that season of 2020-2021, I think it spoke to how contagious COVID-19 was because it was still peaking in the midst of these other viruses not peaking. So I would still expect maybe in the next seasons to see viral co-infections, but we'll just have to wait and see.
It's interesting because I thought the same thing. I was like, all we saw was SARS-CoV-2 that year, and we really saw nothing else. And we did a lot of non-pharmacologic interventions like masking and physical distancing, yet somehow, while it helped maybe curb the SARS-CoV-2 circulation, it didn't stop it altogether, but it seemed to really stop and have an effect on a lot of the other viruses. Obviously, that's hypothesis, and perhaps it was SARS-CoV-2 itself and its interaction with other viruses that may have made that happen, but obviously we don't have a lot of data on why we saw what we saw at that time.
Right. Now, speaking from your role as an ID doctor who works with transplant patients, how does RSV affect the donor-recipient transaction?
Yeah, so if we have a child who is clinically symptomatic, so if someone is waiting for an organ transplant and they are clinically symptomatic with RSV, most times we will delay that transplant from happening. So until they're able to recover from their RSV, we don't want to immune compromise one of these children who have an RSV infection and put them through a major surgery at that time. So we will oftentimes, most times, delay that.
Okay. And finally, for those infants and children in the hospital with RSV, we need to clarify that isolation is required. Interestingly, the CDC has contact and standard precautions, and certainly any hospital makes up their own rules, but they probably at least do that or more. What is your experience?
Yeah, so contact and standard for sure, and we also do droplet precautions as well. These babies are coughing and you're in their face and you're suctioning them and stuff. So having mask and goggles on for a lot of these interactions is important. So we do droplet and contact precautions for our infants with RSV.
Okay. And I think droplet isolation kind of makes common sense as well. Well, today we've had Dr. Statler discussing RSV in pediatrics to shore up our knowledge base about this important topic before we move into adults. RSV for this past season was associated with increased hospitalizations and increased mortality subsequently. Without significant treatment other than supportive care, there's an emphasis on prophylaxis and specific indications for palivizumab. Thank you so much for joining us. This is Forrest Arnold for In Discussion.
Thanks for listening to Medscape's In Discussion Respiratory Syncytial Virus in Adults podcast series with our host, Dr. Forrest Arnold. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on respiratory syncytial virus in adults.